Dr. Nichelle Rothong is with Aurora Neuroscience Innovation Institute. Dr. Rothong is a licensed psychologist whose areas of interest include neuro-oncology, neurological conditions including Parkinson's, medical and mental health conditions that may impact cognition, rehabilitation psychology, neuropsychology, and psychotherapy. Dr. Rothong received her MS in counseling from Syracuse University and a PhD in counseling psychology from Marquette University. She completed an APA accredited internship in clinical psychology at the VA in St. Louis, their healthcare system, in 2014, and another 2-year APA accredited residency in clinical neuropsychology at the VA in St. Louis in 2016. She strives to create a supportive and collaborative assessment process whereby patients and their families learn about cognitive functioning and strategies to manage cognitive behavioral difficulties in everyday living. Her topic today is cognitive and psychological changes in Parkinson's disease. Please welcome Dr. Nichelle Rothong.
Hello, everyone. Welcome. It's great to be here with you all today. So like Gary said, I'm Nichelle Rothong, and I am one of the neuropsychologists over at Aurora St. Luke's in the Neuroscience Institute. And a neuropsychologist is just a fancy way of saying I'm a psychologist that specializes in the assessment of brain and behavior relationships. And so I see a lot of patients with Parkinson's disease for evaluation of memory and thinking skills. And so that's what we're going to be talking about here today, cognitive and psychological changes that can be seen in Parkinson's. And I don't have any conflicts of interest to disclose before we get started. So we are going to start out by reviewing a little bit of background information on Parkinson's disease. Then we're going to move into discussing cognitive changes in Parkinson's and different ways that we might manage them. I'll also talk about psychological and behavioral changes in Parkinson's disease and different interventions that have been found to be helpful. So Parkinson's disease is a chronic, progressive, neurodegenerative condition, movement disorder that's characterized by frontal subcortical executive dysfunction. And don't worry, I don't expect anybody to know what that means yet. We're going to go over that in quite some detail in a bit. The cardinal symptoms of Parkinson's disease include resting tremor, and usually this is a slow pill-rolling type of tremor, bradykinesia, which is slowed movement, and rigidity. Recent revision of the diagnostic criteria for Parkinson's disease removed postural instability as the 4th hallmark symptom, although we know that it is clinically common. Other classic signs of Parkinson's include masked faces, which is reduced emotional expressivity. So individuals with Parkinson's might appear to have a fixed sort of mask-like look on their face. Hypophonia, which is soft voice, can also be seen. Micrographia, so small or progressively small handwriting. Shuffling gait and difficulty swallowing can also be seen. And as we will discuss, the non-motor symptoms of Parkinson's disease have gained attention over the years and are now included among the supportive diagnostic criteria for Parkinson's. So Parkinson's affects 100 to 200 per 100,000 individuals, and the annual incidence rate is estimated to be 15 per 100,000. So what this means is that if we followed 100,000 people over the course of a year, we would see 15 new cases of Parkinson's arise. The incidence has been found to increase with age, and the disease affects 1% of the population over age 60. Early onset Parkinson's, so Parkinson's that develops before age 50, is rare, and we know that men are about 1.5 times more likely to develop Parkinson's disease compared to women. So as I alluded to, non-motor symptoms of Parkinson's disease have gained more attention over time and are now included among the supportive diagnostic criteria of the disorder. So as we'll talk about today, non-motor symptoms include cognitive difficulties, and there's two different types of diagnoses that reflect some cognitive weaknesses that can be seen in Parkinson's. So there's Parkinson's disease mild cognitive impairment and Parkinson's disease dementia, and we're going to go through both of those in detail today. We can also see psychiatric problems, which we will touch on as well. Sleep disturbance, so things like rapid eye movement, sleep behavior disorder can be seen in Parkinson's, and that's where individuals are thought to be acting out very vivid dreams. We can also see excessive daytime sleepiness in Parkinson's. Patients can also be trying to manage pain, sensory disturbances, and also autonomic dysfunction. So things like urinary incontinence, orthostatic hypotension, constipation, difficulty swallowing. And today I'm going to be focusing on the cognitive and psychiatric difficulties that can be seen in individuals with Parkinson's disease. So there are many factors that can contribute to the cognitive dysfunction that we see in Parkinson's disease. And I realize I'm saying the word cognitive a lot. And so cognitive is just a word that means memory and thinking skills, so the different functions of our brain. And so there are a variety of factors that are involved in cognitive dysfunction in Parkinson's. Age has been found to be the greatest risk factor for developing Parkinson's disease dementia. And what the research suggests is that age 70 and older is what we typically see in terms of the risk factor regarding age. And we're going to talk a little bit more about that. There's also a concept called cognitive reserve. And cognitive reserve is our brain's ability to improvise and to find alternate ways of doing things, alternate ways of thinking and remembering things. And it's developed over our lifetime of educational opportunities, work opportunities, leisure activities, and sort of we accumulate cognitive reserve as time goes on. And what the literature suggests is that people who have greater amounts of cognitive reserve are able to better cope with brain damage. So for example, brain damage that's associated with Parkinson's disease. And so what we tend to see is that individuals who have greater amounts of cognitive reserve with Parkinson's can better tolerate more of the cognitive changes associated with the disease while maintaining functioning. In contrast, what the literature suggests is that those with lower amounts of cognitive reserve are at increased risk for developing dementia over time. So genetics, there are certain genetic risk factors for developing Parkinson's disease dementia. Lewy-based pathology, so Lewy bodies and Lewy neurites. Lewy bodies are just abnormal deposits of a protein that accumulate in nerve cells in the brain. And along with Lewy neurites, as well as Alzheimer's disease pathology, so different plaques and tangles that accumulate in the brain. These different pathologies are thought to account for the development of dementia in Parkinson's disease. There are also some other risk factors that I have listed there, like vascular disease and hippocampal sclerosis, that can contribute to cognitive difficulties in Parkinson's. So a wide variety, that didn't go. So there are a wide variety of cognitive deficits that have been found in patients with Parkinson's disease. And the most characteristic deficits are in the domains or the cognitive areas of attention and working memory, visual spatial functioning, memory, and executive functioning. And we're going to go through what each of those areas is in just a moment. Processing speed, or how quickly we think and process information, is also commonly compromised in Parkinson's, though that might be included within that attention and working memory domain. As we will talk about, the profile or the pattern that we tend to see in individuals with Parkinson's disease tends to reflect difficulties with executive functions, and we're going to go more into that. When we think about being able to differentiate between Parkinson's disease and Alzheimer's disease, that can be challenging, especially in the early, or especially in the later stages of the disease, because then the cognitive impairments tend to become more global and harder to differentiate. But in the early to middle stages of the disease process, we tend to see those patients with Parkinson's reflecting more of this dysexecutive profile compared to those with Alzheimer's. So that can be one important way that we might be able to differentiate between the two disorders cognitively. And I would like to just mention that neuropsychological assessment, so coming to see a doctor like me who specializes in assessment of memory and thinking skills can be quite helpful, especially early on in the disease process, in detecting cognitive difficulties and sort of guiding interventions and helping to plan for what we might expect to see in the future cognitively. So now I'd like to discuss the various types of cognitive aspects and different difficulties that might be seen in Parkinson's. So the first area that I'd like to focus on is attention and working memory. So attention is just simply our ability to focus. Concentration is prolonged or sustained focus. And working memory is our ability to hold information in our mind and manipulate it. So for example, doing some mental math, like calculating a tip in our head, or maybe trying to take a percentage off an item at the grocery store. And what the research suggests is that significant fluctuations in attention are commonly observed in established Parkinson's disease dementia. We can see deficits in complex attention. So what this might look like in everyday life is that an individual with Parkinson's has difficulty paying attention in environments where there's many different things going on. So for example, you're trying to have a conversation with the person, but the TV's on, the radio's on, the phone's ringing, there are lots of distractions, and that person might have trouble managing all those distractions and sort of zoning in to what you're saying. The individual also might have some difficulty, for example, recalling an address or maybe a phone number that was just told to them, or maybe even recalling something that was just said during a conversation. Usually that reflects difficulty with attention and concentration, and less so difficulty with memory. So processing speed, and again, this is just our thinking speed, so how quickly, how efficiently we're processing information. And we know that processing speed is commonly implicated in Parkinson's disease. So how this might manifest in everyday life is an individual with Parkinson's may ask you to repeat things that you're saying, or they might seem to be taking a little bit longer following what you're saying or processing information that you guys are discussing. They might need things repeated, and it's just because they are not processing information as quickly or as efficiently as they previously did. So language. So when we think about language, there are two main sort of categories of language. So expressive language skills and receptive language skills. Now, expressive language skills, those include our abilities to communicate via spoken or written language, and receptive language abilities include our abilities to understand spoken or written language. And what we see in Parkinson's is that the core language functions, like our ability to read and write, our vocabulary skills and knowledge, those are typically intact and they tend to remain intact, although we can see changes in handwriting with it getting smaller or progressively smaller as you continue to write. But what we see is that as dementia develops and progresses, patients might display difficulties with word finding. So what this includes is sort of the tip of the tongue phenomena. So you're thinking of a word in your head, but you just can't get it out. Or somebody will be like, instead of saying phone, they'll be like this thing. And they just can't come up with a word for it. Now, I want to sort of hopefully just acknowledge that a certain amount of that is normal. It happens to all of us. Yeah. But as dementia progresses, it might be happening more frequently. As dementia progresses, we may also start to see some difficulties with patients understanding complex verbal material. So complex material that's even shared during a doctor's visit, either that the doctor is reviewing or written materials that are provided. If the language becomes pretty complex or lengthy, patients with dementia oftentimes have some difficulty understanding fully everything that's being communicated. So hypophonia and dysarthria are common in Parkinson's. So again, hypophonia is just soft speech. Our volume tends to decrease over time with Parkinson's. Dysarthria can also be seen, and that is slurred or mumbled speech, so difficulties with the clarity of speech articulation. And as dementia progresses, speech output has been found to diminish over time, meaning that patients with Parkinson's with dementia become less talkative over time. So visual, spatial, and constructional functions. So visual spatial skills are our abilities to perceive visual material in the world accurately. And visual constructional functions are our ability to draw and construct materials. And I don't mean artistic ability as I'm not any good at drawing, but really our ability to draw basic shapes and figures. And what we know is that visual spatial and visual constructional difficulties are usually seen in patients with established Parkinson's disease dementia. And so what this might look like is, in real life, patients might have difficulty judging distances or sort of navigating turns when they're walking. Driving can really come into play with this. And so if people are having difficulty perceiving visual material in their world, they might have difficulty perceiving distances between their car and another car driving, or sort of maintaining a center position in a lane while driving, sort of navigating, making that turn, maybe getting a little bit too close to the curb or the car in front of them. We might also see, again, difficulties with handwriting that can reflect some of this visual spatial change. When we look at Parkinson's disease dementia and Alzheimer's disease dementia, what we tend to see is that those with Parkinson's disease dementia are presenting with more severe visual spatial and constructional deficits than patients with Alzheimer's. And as one of our colleagues is going to be speaking about later on today, visual spatial deficits contribute to an increased risk for falls and fractures. And research suggests that falls are the most common reason for hospital admission among patients with Parkinson's. Memory. So there are two main different types of memory: explicit and implicit memory. So explicit memory is also known as declarative memory. And this is sort of our conscious recollection of factual information. Think back to when we were in school and the teachers are drilling these facts and figures into our heads. That's sort of what's reflected in declarative or explicit memory. Also our memory for events and previous experiences that we've had. In contrast, implicit memory or procedural memory is sort of our unconscious recollection of how to do things. So our unconscious recollection of how to ride a bike or tie our shoes, for example. And studies have found that typically we don't expect to see difficulties with implicit memory in patients with Parkinson's. So we wouldn't expect patients to have difficulties with forgetting how to tie their shoe or forgetting, how to do everyday activities. But we would anticipate difficulties with more of the explicit memory. And so when we think about explicit memory, there's really two different types that we take a look at. We evaluate verbal and visual or visual spatial memory. So in the clinic, when we're taking a look at verbal memory, we're looking at whether or not patients can remember lists of words, stories, conversations that we're reading to them. And then on the visual side, we're seeing if they can remember designs, figures, shapes. And what we know is that the onset of Parkinson's disease dementia memory deficits are usually less severe than those that are seen in Alzheimer's disease. And in Parkinson's, we usually expect, especially in the beginning stages of cognitive difficulties, for a certain pattern to emerge with memory difficulties. And that pattern is characterized by deficits in retrieving information. So here's what I mean by that. So say in our everyday life, we're having a conversation with our loved one who has Parkinson's, and we're talking about something that they're interested in and they're paying attention. But then, maybe the next day or a couple of days later, we're saying, hey, honey, do you remember what we talked about? And they're like, I just really don't remember. I'm not sure. Can you remind me? And what we find in Parkinson's, especially in the early stages of cognitive impairment, is that reminders, those cues, usually help jog that person's memory. They benefit from reminders. And what that tells us is that patients with Parkinson's, they're able to learn new information. They can store it away in their brain, but they have trouble retrieving it or pulling it out. And that's where those reminders, those hints, tend to be quite helpful. And so we have a way of testing that in the clinic. I will say, though, as dementia progresses, that pattern of benefiting from hints is not always seen, and patients' memory difficulties can look like those that we would expect to see with Alzheimer's, where they're not benefiting from cues. So again, how does this look in daily life? So for example, if you're giving a family member who has Parkinson's sort of a list of chores that you want them to work on, maybe five things to do during the day, and they're not writing this list of activities down, they might forget to do all of those activities. They might forget some of them. But again, writing things down and sort of those helpful reminders are oftentimes very beneficial. Okay. Now, executive functions are commonly compromised in Parkinson's. And so executive functions, no one knows. In the clinic, I'm meeting with patients and families, and no one knows what executive functions are, and that's quite all right. I wouldn't expect anybody to. I oftentimes use a sports analogy to help explain what executive functions are. So I know we're in Packer country here, and I would assume most people either follow or like the Packers here. And so I'm going to use our friend Aaron Rodgers as the quarterback of the Packers, or you can think of your favorite quarterback if you're not a Packers fan, to help us understand what executive functions are. So when we think about what our favorite quarterback does in the game, so what Rodgers does, he has to do many different things. He has to plan. He has to organize. He has to think flexibly. He has to think on his feet. He has to solve new challenging problems. He might be planning to throw it to one receiver, but then that receiver was covered, so he has to switch up his plan and throw to another receiver and sort of make that change in the moment. He has to probably do some abstract thinking during the game at some point. Now, all of those activities that Rodgers does during the game, those are all different examples of executive functions. Okay? So our ability to solve problems, to plan, to organize, to strategize, to think flexibly, to think on our feet. All of those different aspects of thinking are commonly impaired in Parkinson's. And what we know is that those difficulties can actually contribute to the memory deficits that we see in Parkinson's. And how this works is that if patients are having difficulties with planning or organizing material, and we're sort of rambling off a list of 10 items that they need to pick up at the grocery store, but they're not able to organize those items in any meaningful way, like all the dairy items together or all the produce or deli items together. If that organizational piece is missing, they might not be able to remember those items later on. And again, it's more reflective of difficulties with organization and planning as opposed to a pure memory deficit. All right, now I'd like to transition to talk about mild cognitive impairment. We've been discussing the common cognitive difficulties that can be seen in Parkinson's. And what we know is that some of those difficulties sort of reach the threshold of more than what we'd expect to see with normal aging. And that's where we start to entertain something called mild cognitive impairment. Mild cognitive impairment is common in individuals with Parkinson's without dementia. And what we know is that about 27% of individuals with Parkinson's meet criteria for mild cognitive impairment, or MCI, as I'll be referring to. And we know that number does vary, and really it's anywhere between 19 to 38% of patients with Parkinson's meet diagnostic criteria for mild cognitive impairment. MCI is a risk factor for the subsequent development of dementia over time, and we know that it is associated with increasing age, disease duration, and disease severity. Studies have found that MCI is common even at diagnosis of Parkinson's disease, affecting anywhere from about 35 to 43% of patients at that initial Parkinson's disease diagnosis. So I'd like to talk about some diagnostic criteria for MCI associated with Parkinson's so that you all are informed consumers. So inclusion criteria. First and foremost, we need to have an established Parkinson's disease diagnosis, and usually that's made by a neurologist. With MCI, we expect to see a gradual decline in cognitive functioning over time. So a decline in executive functions, processing speed, working memory, visual spatial skills happens slowly over time. We can measure or assess these cognitive deficits on formal neuropsychological testing, if you come see a neuropsychologist like me, or on some more briefer sort of general cognitive screeners that take a look at overall cognitive functions. And this last point is very important. So with MCI, cognitive difficulties are not sufficient to significantly interfere with our everyday functional independence. And this functional independence piece is critical because that's the primary differentiator between MCI and dementia. So in MCI, we would expect our loved ones, our family members with Parkinson's, to still be able to perform everyday activities, like managing their medications or finances, driving, doing some household activities, chores, laundry, prepping meals. Now, motor symptoms might certainly make those activities more challenging, but cognitively, so because of their memory and thinking skills, they're still able to perform those activities. And that changes once dementia sets in. So exclusion criteria for Parkinson's disease MCI include a diagnosis of dementia. So if somebody has already been diagnosed with dementia that is sort of further along on the continuum of cognitive impairment, they can't meet criteria for MCI. Also, other primary explanations for cognitive impairment may exclude MCI. And other primary explanations can include things like delirium, and that's an acute confusional state that sort of varies in severity over time. You might see waxing and waning of attention, different difficulties with memory and thinking skills. You might see some hallucinations and delusions. Delirium is commonly associated with UTIs in older individuals. Stroke, major depressive disorder, brain injury, medications can also be primary explanations for cognitive impairment that we're going to want to make sure that we formally work up and exclude before we go ahead and make that diagnosis of MCI. Other Parkinson's-associated comorbid conditions that could potentially influence cognitive testing also need to be excluded. So things like motor difficulties that are common in Parkinson's can impact how patients do on our tests. Significant depression and anxiety, excessive daytime sleepiness, psychosis. So if these factors are present, the clinician really needs to consider how much they might have impacted a patient's abilities to do these memory and thinking tests and our ability to diagnose MCI. So what exactly is involved in diagnosing mild cognitive impairment? we can do an abbreviated assessment or a more comprehensive assessment. So on the abbreviated side, usually these assessments are done oftentimes in primary care or in your neurologist's office. They're cognitive screeners, so the mini mental status exam or the Montreal Cognitive Assessment or the MOCA. There are screening measures that have been designed to sort of give us a snapshot of how somebody's doing in general with broad cognitive skills. And so we would see impairment on these cognitive screening measures, or if we do sort of a limited number of neuropsych tests, we would look for impairment on at least 2 tests. So for example, tests of executive function or tests of visual spatial skills. Now, if we do a more comprehensive assessment and you come see a neuropsychologist like me, we'll probably have you in there for a couple hours and start out with an interview and get to know you better and see how you're functioning in everyday life. And then we'll do a more comprehensive assessment where we're going to test attention, working memory, processing speed, visual spatial skills, executive functions, memory. We're really going to sort of put you through the ringer and see what you can do. And what we're looking for is difficulties that are more than we would expect to see for age and education level. And we're looking for impairment on at least 2 of our tests. And so really what that could mean is difficulty or impairment on 2 tests within that same cognitive domain. So impairment on 2 tests of memory, for example, or 2 tests of executive functioning. So problems with problem solving and thinking flexibly, or problems with visual and verbal memory. Or we can see impairment on a couple tests in different domains. So for example, people can have difficulty with attention, but also difficulty with executive functions. And as I go through with my patients, impairment can be defined a couple different ways, and so that's something that I go through with patients and their family members and caregivers during the feedback when we're reviewing results and how they did. So the clinical profile of MCI and Parkinson's is varied, and there are a wide range of cognitive domains that can be affected, as we've been talking about. And so, as I've been alluding to, there can be difficulties in just a single domain of cognitive functioning, and we refer to that as MCI single domain. So again, difficulties just in executive functions. Or we can have Parkinson's disease MCI multiple domain, where you're seeing difficulties in many aspects of cognitive functioning, like memory, executive functioning, and visual spatial skills. What research suggests is that the most common type of mild cognitive impairment in Parkinson's is within a single domain that is not memory. And so executive functions, those are the domain that is most commonly implicated in Parkinson's. So Parkinson's MCI is a risk factor for developing dementia. And again, it's that non-amnestic single domain MCI. Executive functioning limitations, visual spatial deficits, language weaknesses, and memory limitations have all been found to be predictors for developing dementia. And what we know is that for many patients, MCI is a transitional state before the onset of dementia. However, what research suggests is that that MCI does not always progress into dementia for patients with Parkinson's. And there was a recent 3-year follow-up study that followed patients over time. And what they found is that 22% of patients who were diagnosed with MCI at baseline actually reverted to their baseline level of cognitive functioning over time. So just because you receive a diagnosis of mild cognitive impairment does not automatically mean that that's going to progress onto dementia. But there are some facts and figures that we'll be discussing in a minute that suggest that a good number of patients do progress to dementia. I also want to mention that, again, within that same 3-year study, they found that patients with MCI at baseline had 39 times the risk of developing Parkinson's disease dementia compared with patients with Parkinson's with normal cognition at baseline. So again, it is a risk factor for developing dementia over time. Now, if we transition to talking about Parkinson's disease dementia, so the literature suggests that about 50% of individuals with Parkinson's disease develop dementia after 10 years of having the condition. More than 80% of patients develop dementia after 20 years. And really the average age at Parkinson's disease dementia diagnosis is approximately 72 years old. Now, identifying Parkinson's disease dementia is really important, and it's important to do so early because it has implications for treatment and future planning. Sorry, I'm battling a little cold, so if my voice gives out, that's why. So we know that cognitive difficulties really come into play, especially for our younger folks with Parkinson's who might still be working and say they're starting to have some cognitive difficulties. They've had some for a couple of years, and maybe now they're having some change in their functional abilities. So they're starting to have difficulties managing medications and finances. And that could signal that they're progressing onto dementia. And we need to be mindful of that because this can have implications for how they're doing with work. We might need to start to think about accommodations at work or maybe planning for future retirement. We also need to be mindful of driving and how cognitive difficulties, especially dementia, can impact driving skills and whether or not our loved ones are still safe to be on the road. It's less about, pure driving skills, but more about reaction times and difficulty with thinking flexibly and on our feet, and can patients sort of manage those unexpected conditions that might pop up on the road while driving. And I understand there's going to be another presentation about driving, so I'm not going to go into that any further. We also need to be thinking about difficulties with reasoning and insight and judgment that can be seen with Parkinson's disease dementia. And we know that this can impact patients' abilities to really make sound medical and financial decisions. So starting to think about things like financial or healthcare power of attorney and planning for the future. So those are the different things that we want to be mindful of when we're assessing for Parkinson's disease dementia. And as we know, age is the greatest risk factor for developing Parkinson's disease dementia. So age over than 70 has really been found to be the greatest risk factor. And what studies have found is that folks with early onset Parkinson's had significantly longer survival before developing signs of dementia. Other risk factors for developing Parkinson's disease dementia include MCI at baseline, which we've already discussed, different phenotypes or severity of motor dysfunction that can be seen in Parkinson's. So in Parkinson's, there are two main phenotypes of motor dysfunction, so a tremor-dominant group and a postural instability and gait disorder group. And what the research suggests is that the postural instability and gait disorder group has a higher risk of going on to develop dementia. We also know that lower education and SES, male, cerebrovascular disease duration, facial massing and presentation, all of these other symptoms are risk factors for going on to develop dementia. So when we think about diagnostic criteria for Parkinson's disease dementia, again, it's a dementia syndrome with insidious onset and sort of slow progression over time that develops within the context of established Parkinson's disease. And this is evidenced by impairment in more than one cognitive domain. So exactly what we've been talking about, difficulties, for example, with attention or executive functioning. These cognitive difficulties represent a decline from premorbid level of intelligence. So that just means a decline from sort of your long-standing cognitive abilities. So how you've been functioning with your memory and thinking skills your whole life. And of course, for a diagnosis of dementia, we would expect to see functional impairment. So difficulties, for example, managing medications or finances. And again, these difficulties are due to changes in memory and thinking skills, not motor fluctuations or motor symptoms or changes in the autonomic nervous system. So diagnostic criteria for Parkinson's disease dementia. Associated clinical features include these cognitive features that we've been discussing, but also behavioral features, such as changes in mood, like anxiety or depression, changes in personality, hallucinations. Visual hallucinations are commonly seen in Parkinson's disease dementia, as we'll talk about. Delusions, apathy, and excessive daytime sleepiness can also be associated with Parkinson's disease dementia. Now, when we're assessing for dementia, it's very important that we do a very comprehensive, thorough workup so that we can investigate whether or not there are features that either make the dementia diagnosis uncertain or rule it out. And we really want to consider the time interval between the development of motor and cognitive symptoms. And so this is important because if cognitive symptoms develop before or within 1 year of the development of motor symptoms, then Lewy body dementia needs to be considered. And that's an atypical form of Parkinson's that can have a cognitive profile that is quite similar to Parkinson's disease dementia. We also need to investigate whether there are any other abnormalities which may independently cause cognitive impairment, like vascular disease evident on neuroimaging or a recent stroke. And delirium. Again, delirium is this acute confusional state that can cause cognitive impairment. So that needs to be explored and ruled out in order to make the diagnosis of dementia. So what are some of the things that can be done to manage cognitive changes seen in Parkinson's? So one of the first recommendations that we suggest is a thorough medical and oftentimes psychiatric workup to explore other potential contributors to cognitive difficulties like infection, delirium, depression, and sleep disruption. Medication review is critical because medications that might be prescribed for Parkinson's, like anticholinergic medications, and for years these types of medications have been prescribed to help control the tremor in Parkinson's, and also dopamine agonists. These medications can negatively interfere with cognitive and behavioral emotional functioning, thus causing some of the symptoms that are seen in Parkinson's. So for example, if we think about anticholinergic medications, these medications consist of, for example, tricyclic antidepressants, Benadryl, even some antipsychotics. These medications can cause impairments with memory, different thinking skills. They can cause sleepiness, compulsive behaviors, such as compulsive gambling or eating. These medications have also been found to cause symptoms of mania. Now, when we consider dopamine agonists, these include medications like Mirapex or Requip that can be prescribed for symptoms of Parkinson's. These medications can cause hallucinations, sleepiness, again, compulsive behaviors. So it's critical that we do a thorough medication review to see if any medications that are prescribed might be contributing to symptomology. Pharmacological and psychological treatment. What we know is that certain medications called cholinesterase inhibitors that are commonly prescribed for the memory difficulties with Alzheimer's disease, such as Aricept and Exelon, those medications have been found to be beneficial for the cognitive and emotional behavioral difficulties that can manifest in Parkinson's disease. And so it's important that we talk to our prescribing providers to assess whether any of those medications might be helpful. Future planning. So again, thinking about things like work and driving, power of attorney for healthcare and finance, whether we know our loved one with Parkinson's disease future preferences regarding their healthcare future plans. We want to make sure that we talk about those things early, especially if there's cognitive deficits that are present. And also family support and caregiving resources are very important, not only for patients with cognitive difficulties because of Parkinson's, but also for their family members and caregivers. And through some of those resources, they can talk about strategies for helping to manage cognitive change for the patient and also for families and caregivers. All right, so to end, I'd like to talk about different psychological changes that we can see with Parkinson's disease. And during Parkinson's, many patients experience different neuropsychiatric disturbances, including depression, anxiety, sleep disturbance, different psychotic symptoms such as hallucinations or delusions, behavioral changes. And for patients and families and caregivers, these symptoms can be quite distressing. And sometimes they're even more distressing than the motor symptoms themselves. So frequently, affective disorders, so conditions like depression and anxiety, predate the onset of motor symptoms in Parkinson's. And on average, studies have found that these symptoms can manifest 4 to 6 years before the diagnosis of Parkinson's is made. What we know is that depression and anxiety are quite common in Parkinson's, and depression occurs in about 40 to 50% of individuals with Parkinson's, and we see similar rates for anxiety. Manic and hypomanic symptoms are not well characterized in Parkinson's. Manic and hypomanic symptoms include elevated mood, irritability, hyperactivity, increase in goal-directed behaviors, including risky behavior. And what we see is that in Parkinson's, isolated manic symptoms most often occur as a side effect of a medication, specifically dopaminergic medications, so things like Mirapex and Requip, and neurosurgical treatments. And some patients, though, additionally may manifest some hypomanic symptoms in the on state with symptoms of increased irritability and goal-directed activities. Now, unique to Parkinson's are drug-induced or fluctuating mood states that correspond to some extent to the on-off periods associated with Parkinson's medications. And what we see is that patients with levodopa motor-related fluctuations tend to be more anxious than those patients without motor fluctuations. And in some cases, severe anxiety, including panic attacks, can occur during off periods. And these non-motor fluctuations commonly involve things like anxiety, panic, sadness, or agitation when off. And even when the medication goes on, these mood symptoms can persist. Less often, we can see enhanced well-being or these hypomanic states occurring during the on phases. Now, as I talked about before in the last slide, depression is commonly seen in patients with Parkinson's. And these are some common symptoms of depression. So low mood, not enjoying previously enjoyed activities, declined interest level, pessimism, negative thinking, hopelessness, feeling guilty, being tearful, and thoughts about suicide and death. What we know is that slightly less than half of patients with Parkinson's meet criteria for a major depressive disorder. More commonly, we see patients with Parkinson's have sort of a milder or non-major type of depression, and sometimes this is considered sort of a sub-threshold depression. So, for example, patients who have some symptoms of depression maybe only experience those symptoms during the off states. Depression is more likely to co-occur with anxiety, cognitive impairment, and psychosis. Now, it's important for us to be mindful and to observe our family members, our loved ones, our patients with Parkinson's, to try to figure out if they're showing signs of dementia, if they're showing signs of, not dementia, but depression, or if it's just that their motor symptoms are interfering with their abilities to do their previously enjoyed activities. So non-depressed patients with Parkinson's, for example, may limit their usual hobbies or activities, for example, like woodworking or riding bicycles, because of motor symptoms. But a depressed patient with Parkinson's disease will fail to seek alternative activities, and that's where the depression kicks in. They just don't have that drive or motivation or desire to find alternative activities or hobbies. So hallucinations are common in Parkinson's disease, with rates as high as 65% in patients with Parkinson's disease dementia. And hallucinations in non-demented individuals with Parkinson's are strong predictors of subsequent development of dementia. Visual hallucinations are approximately twice as common as auditory hallucinations, and the majority are complex and well-formed. And so when we think about visual hallucinations, what I mean by that is seeing things, maybe animals or people, objects, maybe in our homes that other people may not see. These hallucinations tend to be in color in individuals with Parkinson's. Now, delusions are less common. Rates are around 17% in overall Parkinson's, and range from about 25 to 30% in patients with Parkinson's disease dementia. Although both delusions and hallucinations do commonly co-occur. And paranoid delusions and something called the phantom border delusion, those are the most common types of delusions that we see in Parkinson's disease. And the phantom border delusion, what that is the belief that there are uninvited people that are living in the patient's home, and they're usually causing a ruckus. And those people are quite distressing to patients. And so it's very important that we're aware that these symptoms can pop up in Parkinson's, and we inform our healthcare providers so that we can explore different treatment options. All right. Now, apathy. Rates of apathy have been found to range from 17% in non-demented patients with Parkinson's and up to 54% of patients with Parkinson's disease dementia. And symptoms of apathy include decreased spontaneity, loss of motivation, reduced interest in previously enjoyed activities, things that are going on in the family, diminished effortful behavior. And finally, I'd just like to briefly talk about impulse control disorders that can also be seen in Parkinson's disease. And dopaminergic medications may lead to impulse control disorders. These disorders have been found to occur in approximately 14% of patients with Parkinson's. And these behaviors may include things like excessive gambling, compulsive shopping, eating compulsively, overuse of dopaminergic medications, impulsive smoking, sort of compulsive behaviors. And again, if you're noticing signs and symptoms of these impulsive behaviors, it's important to let your healthcare providers know because there's certain medications and strategies that can be helpful. So managing psychological changes. So when we talk about depression, again, that's commonly seen in Parkinson's. Antidepressants, certain types of these medications have been found to be helpful in managing symptoms of depression in patients with Parkinson's. We also know that psychotherapy, so learning adaptive, cognitive, and behavioral strategies for managing symptoms of depression and anxiety have been found to be helpful, including having a space to sort of process how somebody's coping with Parkinson's and the associated functional changes, and learning different strategies to help cope with those changes over time. Exercise. We know that exercise is good for us. It's been shown to improve mood, and it can be helpful to patients who are having difficulties with depression and anxiety and Parkinson's. And I know that the American Parkinson's Disease Association has exercise groups, and I think there are even some local groups that might be worthy of exploring. So sleep hygiene is very important for all of us, and especially in individuals with Parkinson's, because we can see excessive daytime sleepiness and also that rapid eye movement sleep behavior disorder. And so there are certain treatments, medication-wise, and then therapy and psychotherapy, different strategies that we can go over to help with sleep-related disturbance. Peer support groups, so they might be helpful for both patients and family members, caregivers, to join these groups, to meet other individuals who have Parkinson's or who are caring for individuals with Parkinson's, to be able to sort of see the things that they're dealing with in their life and different strategies for coping with those difficulties. And we know that caregiver support is also very, very important. And there are caregiver support groups located within Wisconsin and the US. And I do have some caregiver support resources here on this page. So that's all I had for you guys today. I'd be happy to entertain questions, comments, anything like that.
If you have a question, raise your hand. Gary has a microphone.
Thank you. Mm-hmm.
Here you go. I think it's on.
Yes, I am a 6-year survivor of melanoma. I had stage 4 melanoma. I had brain surgery to remove a tumor. And I'm wondering if you know anything or can tell me anything about the correlation between melanoma and the recent findings of Parkinson's.
Sure. So I think I would probably direct that question to the physicians at the end of the day. So I'm not an MD, and so I don't want to give it any medical advice. But what we do know is that melanoma, brain surgeries, different treatments for cancer, like radiation and chemotherapy, can also impact memory and thinking skills. So for many individuals, they have more than one condition. So not just Parkinson's, but they might have had a brain tumor. They might have vascular disease, and so they have these different factors that can potentially impact cognitive functioning. And so it's important that we as healthcare providers really have a good history and are aware of those things so that we can do a nice, thorough, comprehensive assessment to figure out what maybe is best responsible for cognitive symptoms in that patient. Yeah, sure. 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 So there are many different treatments for anxiety, acupuncture. There have been studies about, food preferences and nutrition that can help. Now, again, I'm not a nutritionist. I'm a neuropsychologist, so that's sort of outside my wheelhouse. And I'm not sure if we have any nutritionists here today with us, but I do know that strategies and changes to diet have been found to be helpful. But I don't have any specific information to share with you guys about that today.
Okay, we have a question here.
Yes, I've attended several of these symposiums, and this is another well laid out presentation. I do appreciate what you've given me. I've suffered from Parkinson's for 20 years, and I'm on medication, and I'm using a walker in order to get around. I so appreciate all of the information you've given me today. Thank you.
Oh, sorry. I was like, absolutely. Thank you so much. Okay. Sure, that's a great question. And so you can come see a neuropsychologist, somebody like me, so a psychologist that specializes in memory and thinking skills. And so what we would do is we would bring you in and take you through many different cognitive activities, so things like memory, processing speed, executive functioning activities, to see if you're showing any weaknesses on testing. And what's really important for us to do as neuropsychologists is to estimate or sort of predict where we would expect you to be functioning with your cognitive skills your whole life before the onset of Parkinson's. And so that's what we refer to as long-standing cognitive functioning. And so there are a couple of different ways that we can estimate that. We take into consideration things like educational history, work history, and then more objective measures like word reading and vocabulary skills. And so that sort of gives us a gauge as to where we would expect you to be performing cognitively. And we would expect most people to be functioning right around the average range with our memory and thinking skills, keeping in mind that we all have our own strengths and weaknesses. Some things we're really great at, other things we've never been good at. And so with Parkinson's, what we're looking for is if there are patterns of memory and thinking skill weaknesses that are more than I would expect for your age and education level, more than what we would expect to see with normal aging. And so there are pretty complex ways that we sort of score up all your tests and come to that determination, and that's something that we go over when we're reviewing the results. But again, we're looking for cognitive difficulties that are more than we would expect for somebody your age and education level, and I'm trying to determine if those difficulties follow a pattern that we would expect to see in Parkinson's.
Okay, we have a question here.
What is your opinion of the inclusion of CBD oil in the everyday treatment of Parkinson's with regard to anxiety, depression, and pain management?
Sure. You were probably the fifth patient who's asked me about CBD oil this week in clinic. That question is getting asked more and more. And I will say again, I'm not a physician, so I don't deal with medications or CBD oil. There is research that is emerging that is suggesting that CBD can be helpful for some of those conditions that you're talking about, like anxiety, insomnia. But again, the research at this point is mixed, and I just don't want to go ahead and kind of overspeak or share a knowledge that is not too certain at this point. Yeah. Sure. So it can be a mixture of both. Neurologically, there are many different changes that are happening in the brain with Parkinson's, and so you can see some depression and anxiety that's organic or associated with those changes in Parkinson's, but also you can see anxiety and depression that manifests as a response to the changes that people are experiencing with motor functioning and other areas of functioning in their life. So it can be a combination.
Okay, we have just one more question here.
Sure.
I just want to ask a question about Lewy body disease. Now that is typically mental or dementia at the beginning of Parkinson's, correct?
Yeah, so with Lewy body, you tend to see cognitive impairment that is happening before the onset of motor symptoms, although sometimes that timeline of symptom development is unclear and we don't know, and it can be very difficult to differentiate cognitively, so with memory and thinking skills, between Parkinson's disease dementia and Lewy body dementia.
But when the disease progresses, the Parkinson's disease, you're talking about the possibility of someone having dementia later in the stages of Parkinson's, correct?
Yes. Okay. Yes. As we know, that's common.
Give Dr. Rothong a round of applause.
Thank you.